Great. We'll move on to a little bit more distal. Okay. 71-year-old man fell off an electric scooter, presents with right shoulder, elbow, wrist pain. Since we're working on the forearm, I'll just tell you he had a right posterior shoulder dislocation that was caught by the ED, underwent successful closed reduction. I'll show you the elbow x-rays as well as the wrist x-rays. He's distally neurovascularly intact. Okay. I guess we'll start with Kevin. What are your thoughts here?
On the AP, I see a piece of what I think is the radial head laterally.
Yep.
I mean, other than that, I don't know what's going on with that forearm X-ray on the right.
Okay. I'll move forward to this.
So it looks like it's ulnar positive. It looks like the radius has migrated proximally, maybe.
Yeah.
With that picture.
Okay. Nico, any initial thoughts?
Yeah, so basically, I mean, sometimes when you look at, whenever we talk to our residents, whenever you have an elbow injury, you always have to check the wrist. And if you look at the pattern, it's like a avulsion, so the elbow probably kind of like dislocated. It probably took off some of the radial head. It's like an axial pattern. And one thing about this X-ray is I would probably get a contralateral to make sure that's not like they're normal, but then it's a little bit wide. And whenever you see a little widening on the DREJ, you would think, just by X-ray, that maybe they have the Essex Lopresti would be the injury. But then you could confirm that with the exam.
Yeah. Just like Ugu said, there's, just said coronoid fracture, and then there's coronoid fracture, there's radial head fracture, then there's a radial head fracture as well, right? This is not the fall off a bike, some elbow pain. When I see that amount of displacement, there must have been some sort of instability, dislocation, high energy event, especially with the shoulder and the elbow involved.
I mean, this must have been a self-reduced, at least sublux, if not dislocated at some point, right? Yes. To have that much of an injury at the level of the wrist and elbow, the radial head piece flipping, I don't know, more than 180 degrees where it's supposed to be, has to have some subluxation, significant subluxation / dislocation at some point, self-reduced at some point.
Okay.
And the widening of the DRUJ worries me a little more, to tell the truth, not just the dislocation. I don't know, in my personal opinion, it seems to be that the more wider the DRUJ is, they don't do as well as the other ones. Maybe there's more associated significant injuries, much soft tissue injury more. You guys know better because I should defer you guys for the DRUJ problems.
Yep. So the resident's calling us, managing an ED, the elbow seems to be reduced. Any initial management or any other questions you want to ask the residents as part of their evaluation?
Any elbow fracture dislocations needs a CT scan to scrutinize if there are any other injuries that you haven't seen on the X-ray, in my opinion. Because you always will find something more, most commonly, than you'd not see on the X-ray. Especially for something like this, right? You probably think that it's dislocated at some point, and you want to see any kind of impaction injuries, anything like that.
Just looking at the X-ray, the ulnar styloid looks weird, like he had a prior injury. So maybe that's where he lived,
Possibly. Yeah, I think these are all really great points. Something else I would add is making sure you ask about the compartments as well. I mean, it's not very common in upper extremity, but we've recently had a case where someone came in with ipsilateral injuries to multiple parts of the upper extremity and developed compartment syndrome. And in this case, he did have a shoulder dislocation as well as this elbow fracture. And so I would at least want to make sure that the compartments are okay overnight. So I would have the resident check in the ED and overnight whether the compartments are okay. Okay, so we did get a CT scan. Kevin, any concerns here? What is the CT?
I mean, the radial head is convoluted. It's in a couple of different pieces. it looks like the PREJ is reduced on that axial or whatever that is.
I see a fracture line on the distal humerus. I don't know if it's real or my eyes, but
Yeah.
there may be a little impaction on the posterior part of the capitellum too. This picture tells me that that radial head was dislocated at some point. Radiocapitellar joint.
Yep. There wasn't a fracture there, but yes, I can see what you're talking about, and there was that.
Yeah, I was going to just mention, happy you brought that up, because if you look at the fat pattern, is the radial head probably went posterior and kind of hit the capitellum and got broken, which means that the LUCL probably got avulsed, most likely.
Okay. So what makes you suspicious about instability? I know we sort of talked about this with the radial head, but is it just the radial head? Is it just the radiocapitellar joint?
With any dislocation, you have an, per definition, at least a LUCL injury or some capsular injury, minimum. The ulnar humeral joint looks fine. Possibly, again, if I want to guess, MCL is probably okay.
Yep. So, I think also, as people have mentioned, the DRUJ looks a little bit wide. We don't know if there's a prior injury. We don't know where he lives. I will say we didn't examine this at the time, but when we did take him to surgery, I did check the other side.
The interesting thing, though, I would say, because the length of the radial head is not like a head-neck comminuted proximalized, right? The overall radial head looks fine, but at the wrist, radius looks short,
Yeah.
significantly short, although the radiocapitellar joint is located, right?
Yeah. Yeah. I will say this, and one thing that is also interesting too is, see this, it looks like there's almost widening of the radiocapitellar joint. Now, could that be ligamentous? Could be. But something else it could be, at least on a CT scan, is it could also be impaction. Too. I mean, obviously the radial head's broken, it's hard to see it, but what I'm seeing here.
At the level of the neck, you mean?
Yeah, that it's reduced, it's lining up, but it's lining up because it's impacted.
Yeah, I can see that. The joint is more angulated.
Yep. Okay. Good. So one of the main suspicions, Essex-Lopresti, right? So comminuted radial head, right, and longitudinal instability. I agree that even with impaction, right, the radial height looks very different. Again, we don't know where he lives, but it does make us think, is this longitudinal instability, right? 38% of these are detected, right? That also means that then 62% are missed, right? Most are going to be missed, right? So I've only seen maybe 2 or 3 of them in my career thus far. It doesn't mean that only 2 or 3 of them has seen me. Okay. All right. Anything you would do in terms of evaluation? This patient was discharged, came back to clinic the next day. Anything you would do in the clinic to assess for longitudinal instability, or anything you would do intraoperatively to assess for longitudinal instability? And second question is, as you're working up this patient, would you want any additional imaging? You've got a CT scan already, which we showed, right, as well as films above, below, everything.
Yeah, I've seen a few Essex-Lopresti, and then when I was a resident, I got taught radial head fracture, DREJ, it's unstable, equals Essex-Lopresti. And I've seen cases where actually you have that combination, but the interosseous membrane is actually intact. So it's not always Essex-Lopresti, even though you still have a DREJ dislocation. I had a case where someone fixed a radial head. It was like a malunion. And once we replaced the radial head, the DREJ just kind of popped in. And I still can't figure out how that happened. So for
Do you
me,
think that they were separate injuries, just 2 separate common injuries versus
Yes, sometimes that happens too. I think it's hard to diagnose initially, and there are flavors of them.
yeah. So what I usually do is, the radial head fracture, check the DREJ. I do a squeeze test to see if they have pain in the forearm. If they have a pain in the forearm, I think Essex-Lopresti. Ideally, you get an MRI, but in our institution, it's impossible to get acute MRI. So I would probably treat it like a Essex-Lopresti, and when I'm in surgery doing something with the radial head, then you could do the pull test to see if there's any instability with that. You could do a push-pull test. I probably wouldn't get an MRI acutely. I would love to, but I probably wouldn't get it.
No MRI?
I mean, if we could get it, that would be great, but yeah.
Just FYI.
Or do you want to wait? Do you want to delay and get an MRI?
There's a question.
I'm sorry. The whole time you guys have talked about imaging, what about just a good physical exam? I don't,
What's that, Kyle?
that's when you actually touch the patient.
Wait, what?
We don't know what that means.
I mean, to me, if you're touching them and you're actually doing a good exam, I think you should be able to find these.
I agree regarding the touching the patient, but I think in this, some of these patients, it's not that easy.
So they're not tender in the wrist.
So they have some tenderness. Sometimes you compare with the other side. It's like this, there's tenderness and tenderness, right? So there's a gradation. It's not an all or none. And they do the shock test. It's a little loose, but it's not dislocating or dislocatable, despite the pronation, supination maneuvers. You're like, there's some injury, but is it something severe enough to do something? I don't think it's just that easy. This is like the part that I personally struggle to accurately diagnose what the problem is and what to do when. And I will leave the our hand guys to comment more because they see probably more than I do.
They're much younger, but I know you guys stopped, touching patients a long time ago.
That's offensive.
That's why we have apps.
But my point is it seems like even if it's a little tender more than the other, it has to be a little bit more tender or you don't have an injury there, or it's an old injury. And to me, that's a big difference.
No, of course, if it's negative, it gives you a lot of information. It's like ESR, CRP. If it's negative or normal, that's fine. But if they're not normal, doesn't necessarily always means that there's a disruption of the whole DRUJ.
Yeah, and they've actually looked at this MRIs, and so patients do come in with even just like a Mason 1 radial head fracture, will still have wrist tenderness, but the IOM will be totally fine. So these can be concomitant. You can imagine this sort of fits. It can just be isolated, right? There could be no connection at all. So just because they have some tenderness doesn't necessarily make me think about that. In this setting, he had a lot of swelling, a lot of pain, and too much pain to actually like do a good chuck test.
Yeah, so that I was going to make a comment on that. The acute SSL prestes that we tend to fix, they actually have a lot of, it's pretty swollen actually, and they have a lot of pain. And the thing about the squeeze test, the forearm squeeze test, is that when you squeeze, they're like, yeah, pain, and you ask them where. Sometimes they'll say it's up in the elbow, so it's not at the forearm, And so the squeeze test for me, it's like a plus or minus, but then I think you kind of hit the point here. Like acutely, they're actually much more swollen than you would see just with a radial head in the forearm.
So this is one of the controversies, whether to get an MRI. Is the MRI actually helpful? And does it even correlate with how severe the injury is? And basically, there's studies that say yes, studies that say no. So at least in our institution, it's pretty hard to get an MRI acutely, and I probably wouldn't delay treatment to get advanced imaging, especially if I have other things sort of guiding my diagnosis. Any thoughts about that? Would anyone choose to want to get more information?
I would love to get more information, but like I said, a lot of times they get admitted and they go surgery the next day. Yeah. Like they're the first case at 7:30. You can't stop that, right?
Yeah.
I mean, if you can get it like in a good place to get them, it's great. But I don't think you should delay the surgery because the surgery is probably not going to. The plan of the surgery is not any different. You are just trying to confirm the diagnosis and evaluate the severity of the IOM injury.
Because if you did an MRI that showed a complete disruption of the IOM in this case, which is definitely possible, is there any role for a primary repair of that? Because some people talk about that. So it might change your course.
Yes, I would say yes, but I think the literature is very limited, and the people who are doing an IOM repair or reconstructions are very limited, considering people on upper extremity. I mean, you tell me maybe I'm missing on the hand upper extremity side, but all the papers are almost by one or two authors about the IOM papers, Osterman one and the other one, I can't remember. Very limited. It seems that we all talk about this, but very few people in practice doing any acute IOM or even IOM reconstructions. You tell me if I'm missing anything there.
No, I think you're right. The problem is I've had these injuries where I fixed the top think there's a role for primary repair of this, of the IOM. I just don't know when it is necessary and exactly how to do it, and it's very limited. But I do think there's a subset of patients where fixing the top and fixing the bottom well is not enough. And I've had those patients where I've had bad results despite, I wouldn't change anything what I did top and bottom, but it still doesn't work.
Yeah, I agree. We have some shared patients too. We see these patients delayed. We do everything we can with reconstructions, etc. Sometimes works, sometimes doesn't. Like we do similar things. It's not like the surgery is different.
I can't figure out at the beginning who is going to work and who isn't. That's the issue.
Yeah. I know that we're a little bit short on time, so I'll just sort of run through this. There are a bunch of tests that people have sort of talked about, the radius pull test, the joystick test, which try and translate it. How do they do? Generally only fair, right, in terms of like picking things up. So whether or not it helps you may or may not. Okay, so, but at this point, given his physical exam, we were thinking this is someone who has an Essex Lopresti, interosseous membrane probably out given the contralateral films, pain, tenderness, as well as the radial head injury, okay? Key principles, ORAF versus arthroplasty, you don't want to excise, okay, because it's a primary stabilizer, and you want to do something with the DRUJ or just the connection between the two, right? Okay, can you guys play this video? So in the OR, I've already excised the radial head, right? I've already taken care of the radial head. And what do you see here, Kevin?
It looks like the radius is moving significantly as you stress it.
Yeah, so I'm just applying an axial load, and here it's actually much more dramatic than I thought it would be, just how much shortening that they have.
Can you tell us exactly what you're doing? You are grabbing the proximal radial shaft with a lobster claw
No,
clamp?
I'm having the arm up like this, and I'm just sort of applying.
Okay, just
axial load.
manually through the wrist.
Yeah.
I see.
Yeah, yeah.
So you are pushing on the hand or the palm of the wrist,
Yeah.
trying to push the radius more proximal, basically. Okay.
Is that before you fix the radial head?
No, I've already excised out the radial head. I first approached the radial head.
You've already done the radial head arthroplasty, and then you're doing
I've not done arthroplasty yet. This is just me.
So radial head is out.
radial heads out, you're doing that.
Yeah.
Well, that would occur regardless of whether you have an injury to the interosseous membrane.
I think it will be more helpful if you do this test with the radial head fixed or replaced, I guess. That's what you are trying to say?
If you take the radial head out and you do that test, wouldn't that show some instability or
No.
This is pretty
Not this
dramatic.
much. So, yeah, at least in the cadaver studies, now remember, cadaver, not human, but we wouldn't expect this amount.
I mean, it's not like a millimeter ulnar plus or two, right? So this looks like the whole diameter of the ulnar head's amount, the
Yeah,
translation.
I think one of the cutoffs that's thrown out there again, nothing final, like 2 or 3 millimeters, whereas this is like 7, 8 millimeters. Okay. More of the same, showing how dramatic that is. And this is me actually just pulling on the radial head itself. So I find this test less useful because the main issue is going to be longitudinal instability rather than transverse instability, but just something academic. Okay, so did a radial head arthroplasty. So, and I don't know the answer to this, so for the panel, how do you judge your radial implant height in the setting of longitudinal instability, right? One, you don't want to overstuff the radiocapitellar joint, but you're also combating the proximal migration of the radius.
I know it's difficult, but I still use the same things. I try to see relative to the lesser sigmoid notch, like from the lateral view. This is one data point, and I shoot an AP X-ray. I still look at ulnohumeral joint, radial side versus ulnar side of the ulnohumeral joint. I think this gives you a very good idea where you are supposed to be. If you have these 2 points lined up, I don't see much problem about the longitudinal overstaffing. I don't know anybody else using anything differently.
I think where sometimes people get in trouble is that they keep putting a bigger radial head to basically get it to like ulnar neutral or whatever the patient's variance is. And I think that's when you end up overstuffing. When I do like a radiohead arthroplasty, the key thing that I look at is actually intra-op. I look, with my arthroplasty, I want to see like a millimeter of the PRUJ. So when I put my arthroplasty and I can see a millimeter of PRUJ, I'll probably take a shot of the wrist to make sure I like the length. And then I have a lot of thoughts on this, as to what do you do with exoskeleoplasty. I actually have a lot of thoughts, but no answers. But then what I was taught to do is after you do a radiohead arthroplasty is you pin it.
Okay, I'll show you what we did. So the first thing was that I wanted to get contralateral wrist imaging, right? I got it in supination, I got pronation, just to know where does this person typically live and how does the DRUJ line, right? Just getting some basic information. Go in there, put in the radial head, and I actually started with the patient's native anatomy, right? You're just measuring the radial height based on how much you excise, also understand that there was some impaction, and I put that in, and I got a lot of ulnar positivity, right? And so I just kept putting in more up to like +6 beyond that, Nico, and it didn't change the ulnar variance at all. So I can't explain that. I'm not sure if anyone else has any other opinions about that, but despite my going up dramatically in size, it didn't change the wrist alignment.
I think that this longitudinal translation force is actually much higher. It's incredible because I've done reconstructions and it looks good at time 0 and then they fail, you know?
Yeah. So what I did was say, okay, well, let me take a step back and not overstuff the joint. Because right now what I'm seeing is that I'm not changing the ulnar variance. So I put in the head that I thought it would be based on the patient's native anatomy and based on what you had mentioned, and basically pulled longitudinal traction on the arm until I was able to, like, essentially fighting the longitudinal instability to get to the roughly about where the ulnar variance should be based on my contralateral films, and then looked at my elbow with sort of that traction view to see how it matches up radiographically as well as clinically. But I did consider just pinning the DRUJ in a reduced position to also help with that. Thoughts, criticisms, jeers?
Which position of the forearm rotation you pin the DRUJ?
Oh, I didn't do that at all. I thought about it. I did not do it.
So in this case, you did not do anything to DRUJ?
Oh, you'll see. And you can thank Nico for that one. Okay. Can you give a show of hands? How many would pin the DRUJ? Okay. How many would deal with IOM? Nico,
Yeah.
because he's the one who's like, let's do something to the IOM. So I was like, fine, we'll do it. So we ended up doing an IOM reconstruction. Okay.
Just like Mike, you mentioned this about acute. The problem I've seen is that when you pin the DRUJ, right, you just pin it. So we know you can't just repair the central band. It doesn't work. It fails. But when you pin it, what happens is in the mid forearm, you get a lot of muscle herniation. So the IOM is not going to heal. I don't think it's going to heal. And so in the literature, really, I mean, people talk about different techniques, pinning it. Dr. Osterman had a long time ago, I'm not sure if he published this yet, but he was talking about doing tightrope acutely in the interosseous membrane sort of direction, central band. I haven't seen that publication yet, so I'm not sure what happened. But then for me, just pinning it, I've done that more than I've done an acute reconstruction, but it just didn't make sense to me. And so since I see this late and I do the late reconstructions, a lot of times when you see it late, you have to actually shorten the ulna because you can't, they kind of get socked in a shortened position. And when you shorten the ulna, what you have to do is you have to put your interosseous membrane around your osteotomy, so it gets a lot more complicated. And so, you know, I've been thinking about this, why don't we just do it's pretty easy actually to do an interosseous membrane reconstruction, so why not just do it acutely? So.
Yep, and that's what we did. So basically what I did was, you're sort of identifying where the tunnels are going to go, and I think for this one we used tenodesis screws. You know, you're angling roughly 21 degrees off of the axis, you know, and roughly about 60% of the radial length from distal to proximal. and you're ending up at 33%, a third of the length of the ulna distally.
Just a technical point. So I said it was pretty easy, but so basically where your BR is, and there's a muscle, and then you make a incision about this big, and then if you go down, you'll see your pronator teres inserts, and that's basically where your central band kind of starts. And from there, you go dorsal, and you go, Dr. Julie Adams sort of wrote about this 21 degrees, but then I don't use a goniometer. I just kind of pull on it until I get my tension, and then I secure it in the ulna.
What's the reconstruction done with?
We use semitendinosus. Yeah, use allograft.
Yeah, usually I use semitendinosus. I use two, tenodistal screws, one in the radius, one in the ulna. And then on top of that, I like to supplement it with an endo button on both sides.
Go ahead.
What do you think of use of tightrope for acute fixation of DRG?
Yeah, I know Dr. Osterman was had a series. If it worked, it'd be great. But then it's the same concept to me. Like if you use a tightrope, the interosseous membrane still is not going to heal because of the muscle herniation. So I think for me, I have no data for this, but I think if you don't put something like biologic, with time, it's going to fail.
Well, it's kind of like when a lot of trauma surgeons use with K-wires,
Yeah.
right? And the tightrope would be kind of the same thing. Instead of the K-wire, it's a tightrope, and theoretically, if it's acute things with scar-in type of thing.
But I think the tightrope Nico's mentioning is in line with the intraosseous membrane, not at the DRUJ level, not in line with the K-wire trajectory.
Orbe, and I've seen him and Deanna Mercer give talks, and they put one across and then an oblique one, so they do two.
So they do the distal
Yeah.
sort of bundle or the distal.
They do
Yeah.
Because just transverse one doesn't make sense, right? It's not going to affect the proximalization. It's just medial lateral. This, yeah,
Table like this as well.
yeah.
The transverse one retraces the two K wires, and you also do the interosseous.
Yeah, I've done interosseous. I've done tightrope for unstable DRUJs, but for me, until I see data, I just don't understand. I think it'll work at time. I'm not sure. Maybe it'll work for a year or two, but I feel like if you don't do something biologic, I think with time it'll just fail.
But if you
I
have
don't
an
know.
acute, if you have an acute DRUJ injury, right?
Yeah.
There is some biological response to healing, just like the syndesmosis. If you get it in the right spot for a while, it'll heal in place. So if you have an acute injury with some healing response, it might be enough for the DRUJ, because that's a favorable biological setting compared to IOM.
Yeah. So I think where the DRJ, I think you can fix the DRJ, but I think in Essex Lopresti, just like you showed with, once you get this longitudinal instability, it is just so, I think it will overcome your DRJ scarring. So I feel like you need something central.
But sorry, and I meant with regards to DRUJ, you do it for DRUJ.
Usually, I've done it in the past, but then usually for DRUJ, I do like a Adams burger reconstruction with a graft.
Do you ever do TFCC repairs, primary TFCC repairs in this setting?
So I have a talk on that on Saturday.
Okay,
So,
we'll save it for then.
yeah.
Yeah, I mean, to your point, it would almost be similar to doing an acute repair of TFCC versus doing some sort of
Yeah.
tightrope.
Yeah, I mean, everything I'm talking about is just thoughts. There's not a lot of data out there,
Yeah, and I think the case numbers are so small, we don't have it.
And the problem is, I think I've seen 5 in my career in the trauma hospital, but then you might go your career without seeing one, maybe,
Great. And this was Lay's follow-up. He is, I think, still only 3 months out and very, very stiff. So what is your post-op rehab protocol for this? Do you let him move quickly because you've done a ligament reconstruction? Do you still protect him?
Yeah, for me, when I do the reconstruction, I actually munster them for about 6 weeks. So they just do flexion extension, no rotation. But I know it takes longer for the allograft to incorporate, but I just don't feel comfortable locking them up for 3 months or longer. So I just do 6 weeks.
Would you move him soon or protect him?
I think 6 weeks is about right.
Okay, that's what I did, and now I'm like, maybe I shouldn't have, but I don't want this to fail, right? I think he's going to be far worse if this fails and has to do sequential surgeries.
So is the forearm stiff, correct?
Yeah.
Or elbow is
His
fine?
elbow's fine. His elbow's actually pretty good. It's just that he has very little pronation supination, maybe like 10, 20 degrees each way at his like 6-week visit.
I mean,
Oh, that's not bad.
Sorry, at his
why to immobilize so much, so long, right? If you do an ACL, whatever, you start moving the knee, right? It's a ligament reconstruction. All the basic science data will tell you that ligament tendon repair reconstructions, if you start some kind of motion, actually they reconstitute better and they heal better. Again, I'm just arguing.
Yeah. No, that's why I asked the question, because maybe I should have, right? Because we do that for the ACLs and because we do that with other joints.
There's probably a pivot point somewhere, like not day one, but maybe somewhere between 1 to 6.
Yeah, totally. I mean, you could use like an internal brace too, right?
Like if you're doing this reconstruction and you've got sort of a bidirectional longitudinal instability, you're only going to be tensioned in one direction. There'll be slack going the other way.
Trig asking why you're not doing double bundle.
Yeah. Yeah, so you can make them tight if you have to be careful when you tension this reconstruction, you want to do it in neutral. The intraosseous membrane is basically taut all the time. So it's not like it loosens when you supinate or pronate. There's like data on the wrist, like the palmar and dorsal radial ulnar ligaments. There's different tensions. And that it's also even controversial as to when they're tense, but that's not the same for the central band. It's always tense, like it's I guess isometric. Yeah.
Sounds like our knowledge is really not great.
I did not.
You just did the.
Yeah. In terms of like techniques and what's been published, it's always usually one thing, like either the reconstruction or it's pinning.
Yeah, and we didn't go after the TFCC either.
Yeah.
So now that he's only got 10 degrees of pronation and supination, that's going to be a permanent, what's your fix for that? A swabbing?
Well, it's only 2 months that was on, so it's just a lot of.
We will send it to you to the IOM release.
He has a year to rehab, so.
Stiffness is okay right
Yeah.
now. Instability right now is not.
Yes.
This thing can work out. Instability now, you're dead in the water.
Absolutely, and that's my biggest concern is that this would fall apart, things would come loose, because then we know what the path is, and it's just disaster.
The DRJ looks great. I think he's right.
We'll see what happens next year. We could present this and
Or,
see what happens. Maybe we'll present it, maybe we won't.
if we don't, you'll
Yeah.
know what the outcome is.
If he does well, we will present.
Yeah.
What clinical photos of our patients?
All right, great, thank you. So is that it? Do you have anything?